Can imipenem, cilastatin, relebactam be a safe and effective alternative to piperacillin, tazobactam in patients with hospital-acquired or ventilator-associated bacterial pneumonia? The study aimed to evaluate whether IMI, REL, a beta-lactam, beta-lactamase inhibitor combination, could match the efficacy and safety of Piptaz in critically ill adults with HABP or VABP. What was the approach? 270 adult patients were randomized to receive either intravenous IMI, REL or Piptaz every 6 hours for 7 to 14 days. All patients received initial empiric linezolid for MRSA coverage. The primary outcome was all-cause mortality at 28 days, with clinical and microbiological responses as secondary endpoints. What did the study find? IMI, REL was non-inferior to Piptaz. 28-day mortality was 11.2% in the IMI, REL group versus 5.9% in the Piptaz group. The adjusted difference was within the preset margin for non-inferiority. Clinical cure rates and microbiological eradication were comparable. Emergent resistance during therapy was lower with IMI, REL. Adverse events were similar between groups. Most were unrelated to study drugs. So, what were the strengths? Inclusion of a critically ill, real-world population. Strong microbiological data. First major HABP, VABP trial involving Chinese patients. And the limitations? Slightly higher numerical mortality in the IMI, REL group, potentially due to pre-existing cerebrovascular illness. Low mortality in the Piptaz group may skew interpretation. Exclusion of immunocompromised and dialysis patients limits generalizability. Bottom line, IMI, REL offers a viable alternative to Piptaz, especially in regions with high resistance rates. It should be considered in settings with MDR pathogens, but local antibiograms, cost, and stewardship policies should guide its adoption. Should we change our practice? Possibly yes, particularly when resistant gram-negative infections leave few other options.